It's the weekend. Be good to yourself. It's Katz's Corner with Dr. Aaron Katz and Dr. Philippa Cheetham, where you can get simple, straightforward answers to your questions about health, from diet and supplements to lifestyle changes. To reach Dr. Katz and Dr. Cheetham, call 800-848-WABC. Now, live on 77 WABC, the chairman of urology at Winthrop University Hospital in New York, with co-host Philippa Cheetham, attending in urology at Winthrop University Hospital. Here is Dr. Aaron Katz.
Good morning, everyone, and welcome again to another live round of Katz's Corner here on WABC Radio in New York. I'm your host, Dr. Aaron Katz, and we are live at 1-800-848-WABC. That's 1-800-848-9222. If you've got a question about your health under the belt, give me a call at that number. We've got a wonderful guest in the studio with me this morning to teach us all and tell us all about the latest and greatest about sexual health for our men and, of course, our spouses. And I want to remind everyone before I get to our guest that the registration for the prostate health seminar is open, available. The website is up, and it is filling up. So you need to get on there and register today. That is menshealthseminar.com. That's our annual Men's Health Seminar Conference at the Garden City Hotel. It'll be June 15th this year. It's going to be a wonderful seminar, as it was last year. We had close to 300 people last year, and we expect more this year. A full-day event. That is menshealthseminar.com, and we hope to see all of you there. This morning, I'm very pleased and so proud to have in the studio with me a wonderful guest, a colleague of mine at Winthrop. His name is Dr. Brett Mellinger. He is an attending at Winthrop University Hospital, and he's also an associate clinical professor at Stony Brook, and he is really an international, a world expert in erectile dysfunction, and is going to tell us all about how to evaluate and treat and take care of men who are having problems with low testosterone, as well as having difficulties with erections. Good morning, Brett.
Good morning.
And thanks for coming in so early this morning. And I know you don't live too far from here, so you work out in Long Island with us, but you don't live too far, right?
Yeah, I'm very happy to be here.
So you've been doing this for quite a bit, and I know that you're involved in all of the societies, the sexual medicine societies, and working out at Winthrop for many years. What do you think? Is it getting worse, this problem, or are we just becoming more aware of it? The actual ability or the inability for men to have a good quality erection?
Well, I think there's definitely increased awareness, especially when Viagra came out about 12 years ago. So now we see a lot of advertisements on the TV for, the known medications, as well as ads for, nutraceuticals, so to speak, other options for men. But I think also it's probably increasing because we have an increasing incidence of diabetes in the United States, especially in New York City. So, and there's that is what we call a risk factor for erectile dysfunction. It's a common medical condition that can lead to what we call ED. So it's probably a combination of both, increased awareness and increasing obesity, increasing diabetes, and that can lead to low testosterone as well as erectile dysfunction.
Yeah, so you say diet and obesity. I mean, how does that affect the quality of an erection? Can that is it a cholesterol factor, or is it just the amount of fat that you have in your body that can clog up the arteries in the penis?
Well, it's often I always say multifactorial. It's often multiple causes, but for most patients who come in with a complaint of difficulty with their erections, they often have medical conditions that we call risk factors that are known to be associated that can lead to erectile dysfunction, such as I mentioned, diabetes, high cholesterol, even high blood pressure, smoking, tobacco use. All these can cause vascular disease, which is the more common reason men have problems. It's usually vascular.
Yeah, and do you think that it's reversible? Like if you see a guy in the office this week, and I know you see probably over 100 men each week with this out at Winthrop. And by the way, Dr. Brett Mellinger, his phone number is 516-873-5353, really an outstanding physician who evaluates and treats men with erectile dysfunction each week. And if you see a guy that, he walks in the office, let's say he's 50 years old, he's overweight, maybe his sugars are starting to climb, his cholesterol's up above. If you say, listen, rather than going to the Viagra, to the quick Band-Aid effect, if we, change your lifestyle, if we work with you, is it, can it get better? Can it be reversed just alone with those methods?
Well, you can certainly improve the quality of the erections, but for many men, you're not going to completely reverse the process that leads to erectile dysfunction, especially when they have underlying medical conditions such as the diabetes. So obviously, if we can start earlier in men who are younger before they develop ED, because at that point it's usually irreversible, and maybe modification of diet and lifestyle later on can improve the erections but may not totally reverse it. So I think the message we want to try to get out is try to change early on in your life, healthy living, healthy diet, a heart-healthy diet, which I know you talk about here frequently as it relates to prostate health, is also helpful for erections, fertility. So patients ask me, what can I do? What's good? What should I be eating? I say, well, you think what's good for your heart is going to be what's good for your erections. And we just heard recently about the Mediterranean diet reducing the incidence of coronary disease and heart attack. So I think that will also apply to reducing, or improving the quality of the erections if you can exercise, change your diet, and you will improve it. But for many men, by the time they get to my office, they have irreversible erectile dysfunction.
So the window, the penis is the window to the heart. Is that right?
Absolutely.
Yeah.
It tells us a lot about the health.
Yeah, it certainly can. And if you're a younger man, let's say you're in your 40s or 50s, and you're coming in and there's a change of the erections, well, what are the first things that you do? When you're in your office, man's coming in, and let's say he doesn't have diabetes, and he's not on any other medications. So we've had a few callers, actually, Brett, that have called in saying that they're on high blood pressure medications, and they found that this can affect their erections. Is that your experience as well?
Well, just about all the medications for high blood pressure have been associated with erectile dysfunction, although high blood pressure itself is often associated with erectile dysfunction independent, meaning regardless of the medication effect. And there's some feeling on part of many experts that patients who start medication to reduce their blood pressure can experience erectile dysfunction because many of these patients have poor blood flow to the penis. So you have basically a high pressure forcing the blood through these restricted arteries so that they can maintain their erections. But once we lower their blood pressure, which is appropriate, which you have to do because you want to prevent heart attack and stroke, then they don't have that same forcing the blood across these bad arteries in the penis. So there is some medications which are notorious for affecting what we call the beta blockers and the thiazide diuretics, such as Lasix. That's been associated. But again, many experts feel it's the underlying disease itself that is the factor and not the medication.
So the guy comes to your office, and what do you? Because I know a lot of doctors probably just say, just take a Viagra or a Cialis, and then come back and see me in 3 months, and hopefully it'll work for you. And there's no talk about diet. There's no talk about stopping smoking or trying to change the fat intake. But beyond that, what do you do physically to these patients? Do you examine them? Do you do blood tests?
Well, obviously, we want to get a good history. You want to get a good medical history, medication history. And also, let's remember that we're talking about erectile dysfunction, but there's somebody else involved, and that's his spouse or his significant other. So we want to get a sense of what the quality of the relationship is, because that can also, of course, affect the erections. So it's not always just a physical cause itself, but the psychological effect, the relationship that man has. So it's important that I get a sense of what the relationship and what the motivation is. And then obviously a good physical exam and focused exam, and obviously an examination of the prostate when appropriate, because we are urologists. And then appropriate blood testing. I advise everybody to get a testosterone level. It's important to check that. And when appropriate, if many patients are already seeing a physician, so they may have already had their cholesterol and their lipids checked, and it's important to see what that those tests have been done. And then a good focused exam, examining the penis, looking for any scar tissue, any abnormalities. may do a brief assessment of the neurological in terms of sensation. And then quite often I may advise the patient to consider a test to measure the blood flow to the penis, which is the more common reason men have problems. It's usually vascular. So it's a test that's been, described over the past 30 years that gives us some information regarding the blood flow and the ability of the penis to trap the blood. So it uses a special instrument called a ultrasound Doppler. So with that, we can then determine, is it a blood flow issue? Is it a neurological problem? Is it psychological? And for most men, it's a blood flow. So if I have a 50-year-old patient in my office who's complaining of quality problem with his erections, I think it's very important to evaluate that patient because this can be a predictor of impending cardiovascular disease. So we can have an impact on that man, and I'll often send these patients to our cardiologists at Winthrop to get further evaluation to see if they do have any evidence of impending cardiovascular disease.
Excellent. So you're really getting a full assessment of the patient rather than just the Band-Aid effect of take the Viagra. And then I guess there are some times, probably many times, where you do this and you find it's a blood flow problem, and then there's a number of medications. There's the Viagra, the Cialis, the Levitra. I mean, how do you know what to choose from? I mean, is it just the flavor of the month, or is it based upon side effect profile or other medications that guys are taking? Or
well, obviously there are a couple conditions where we can't prescribe these medications, such as a man who may be on nitrate medication or nitroglycerin for heart problems, because of the combination of that kind of medicine with, say, Viagra can dangerously lower the blood pressure. But most of the time, we're gonna try all the medications because we want to see, how that man responds to the oral therapies before we move on to what we say second line therapies, more invasive type therapies. And often, sometimes one patient may not respond to one medicine, but may have a better response to the other. And it's also important that when I talk to a patient who may have tried the medicines before, I want to ask him, what dose did he use? Did he use the highest dose? Did he wait long enough after the medicine? Most of the time, patients need to wait at least an hour after they take these pills before they attempt sexual activity. So if a patient tells me he took the low dose, he only waited 10 minutes, that's not an appropriate way to take the medication. So we have to counsel them on the appropriate way to take the medication and make sure they're taking it and waiting appropriately and that they're getting the stimulation from their spouse. And then if they're not responding to, say, Viagra, we may try the Cialis or the Levitra before we really then consider, well, he's not really responding to these treatments. I think it's also important that our audience know that it's a revolution in terms of treating ED when these medications became available, but they don't work in everybody. Maybe in 40-70% of patients they will be effective, but there's a lot of men where they just don't give that good quality erection.
7:16 in the morning. If you're just waking up, Katz's Corner. My guest this morning, Dr. Brett Mellinger, attending urologist at Winthrop University Hospital and also an expert in erectile dysfunction. As you're hearing, his phone number in the office is 516-873-5353, or you can always get more information at winthrop.org. So, Brett, you're bringing up some very fascinating points about the use of Viagra. I think a lot of guys just want to, well, some guys I see in the office, they say, Dr. Katz, I don't really want to go on that medication because I don't want to be kind of addicted to it. I feel like I'd like to try other methods, maybe lifestyle methods, change my diet, stop smoking. Use more aerobic exercise, because once I feel like if I do these medications, I might be dependent on it for the rest of my life. Do you think that's true?
Well, for many men, they'll really need the medication to have a good erection, even despite changes in diet and increase in their exercise and avoiding the smoking, because many men, by the time again they're coming to our office, they've already had some significant changes in terms of the blood flow to the penis. So certainly it can improve things, and I see patients just like that too who say, I don't want to take it because I may become dependent. But in the end, many of these patients, I will advise them, you really should take this medication because it's really going to help you, and most of these patients will respond.
And then if the medications don't work, and I know that you are probably one of the guys that do the most number, 80% actually, of the penile implants. This is actually a surgical implant where you've already, I guess, tried the oral medications. Maybe you've tried, and we'll talk about in a moment, the injection therapy. And then, you put in probably over, close to 100 penile implants a year, which then once you do that, you fix the problem. obviously it's a surgical procedure you have to go through, and there's risks. What do you think? I mean, how are those working out? Are patients very satisfied when they have that implant?
Yeah, well, we consider the implant the permanent solution.
And also, are their wives satisfied?
Oh, very, very high.
Yeah.
You know, it is when patients reach that point. You know, they've usually tried the other treatments. Oral therapies have failed. Maybe they're not candidates for some of the other invasive therapies like injection, which we'll talk about. But the implant has been around for decades and is actually one of the most successful treatments for ED. It has the highest, what we say, satisfaction rates. When we talk about success with our ED treatments, we talk about patient satisfaction.
And does insurance pay for that?
The vast majority of insurance does cover it.
Okay. What about Medicare? Does
Medicare,
the government
so far,
pay for it? So far.
That's
we'll see
still,
this week, right?
Yeah, that's still covered. They didn't eliminate that with the sequester.
Oh, no, they're not going to. That would be a huge political mistake, right?
Yeah, I think we'd have some angry men and their spouses.
No doubt about it. So they have to go through a surgical procedure, but once you do it, it would take you about an hour to do?
Yeah, it's a pretty relatively simple outpatient procedure, so there's no stay in the hospital. It takes an hour. Patient goes home that day. Most patients need maybe a week or less recovery, depending on what kind of work they do, and then usually healing's complete within about a month or so. And the advantage of the implant is it's very spontaneous, sensation, climax, orgasm the same. And as I tell patients, what an implant will do will allow a man to have an erection when he wants it, as long as he wants it.
As long as he wants.
As long as he wants.
Because you hear these commercials, you know, if you're on Viagra and if you have erection more than 4 hours, see your doctor immediately.
Well,
but that doesn't. I mean, not that you're going to tell him to have an erection for more than 4 hours, but you could with the implant.
Oh, you could, yeah, or until your wife or spouse says, you know, that's enough already. But yeah, I don't need to go to the emergency room if you got that 4-hour erection. That means you just haven't deflated it.
You know, the phone lines just lit up with about 300 women calling. Right? How do they get that implant? And is it painful to go through that? Because I know guys are probably thinking, "Oh God, you know, you're gonna."
Well, there is pain for some patients. Some have. You know, everybody has a little bit different pain tolerance. It's controlled with the pain medicine. Yeah. So that usually that pain discomfort is usually resolved within a week or two.
And it's all on the inside, right?
All
it's
inside.
Like the penis still looks normal.
Completely.
It's not hard all the time.
No.
It's just hard when you want it.
Right.
And how do you make it hard? You use a pump or something in the scrotum? Or?
Yeah, it's a sort of like a hydraulic system. And it's very concealed. So there's 2 cylinders that go into the penile cylinder. A reservoir holds the fluid because it acts like a hydraulic. And basically it's a little ball in the scrotum. So a patient can feel it but can't be seen. So if he's at the gym in the locker room, nobody could tell by looking at him.
Yeah, and then if you want to have the erection, you just you teach them in the office, I guess, how to pump this hydraulic system up, and then you're ready to go.
Ready to go. 10, 15 pumps, he's ready to go.
Do you think that the erection, the quality of the erection with the implant is better than with the oral agents?
It certainly can be as hard as that man wants it to. I mean, it's just a matter of how much he's going to pump it up.
Yeah.
So, and the advantage is, again, even after orgasm, he's still hard. So it stays up until he just there's a little release button on the pump. And once he presses that, it goes down again. So it can't go down accidentally. It doesn't go down after orgasm. The erection stays as long as the man and his partner or spouse want it to stay.
So it feels normal, looks normal, and the orgasm is normal.
Everything's normal in that regard.
Okay.
All those functions are the same.
Well, if you have a question about this, we have a few moments left at 1-800-848-WABC. That's 1-800-848-9222. We're speaking with Dr. Brett Mellinger, attending urologist at Winthrop University Hospital. His office number is 516-873-5353. You do these implants at Winthrop, Brett?
Oh, yeah. We've been doing them at Winthrop since I've been there for about 15 years now.
Is it outpatient or they have to stay overnight?
No, it's outpatient. They go home that day.
Really? That day? And so they come in, go out, and then when can they start using it?
Probably within about a month for most patients. 4 to 6 weeks.
4 to 6 weeks. So chill out for 4 to 6 weeks, and then, honey, it's going to be the best ever.
Well, that's what often patients say. One patient came in the office the other day and said, best sex he's had in 20 years. So.
Wow, is that right? Yeah. Well, good for him, and good for you for doing this. We'll take a few phone calls. Guys, let's go to Carl. He has a question up in Orange County, New York. Good morning, Carl.
Yeah, good morning, Doctor. How are you?
Good. How are you doing?
Okay. Well, we'll know after we have this conversation, I guess. I'm 63 years old. I'll be 63 at the end of the month. Last September, I had a radical robotic prostatectomy at Mount Sinai. and the doctor who performs the procedure has a technique that identifies the various nerves and blood vessels that are necessary to maintain for sexual activity and incontinence. The incontinence part has been wonderful. I was incontinent for probably 2 weeks after the procedure, and that has resolved itself, and that's fine. But the ED part has kind of remained, and I'm just wondering. I have thin optic nerves, and I was on Cialis for a couple of weeks, and I found that my eyesight was affected. So I'm very concerned about taking any medications that have that side effect. I'm in perfect health. I'm a non-smoker. I don't have any heart problems. I'm
okay.
Zero medications now.
Let's ask our expert here, Dr. Mellinger. What do you think? First of all, robotic surgery. We do a lot of robotics at Winthrop, but some of these men can have this side effect. What do you think, and how would you evaluate him?
Yeah, unfortunately, the robotic surgery and the technique of a radical prostatectomy is improved such that the incontinence is not as big a problem as it was in the past. But unfortunately, the ED can still persist. So when patients, after that surgery, many don't respond to the oral therapies, or as Carl's experiences because of visual concerns, is concerned about taking it. Next line therapy may be considering penile injection therapy, either with a single agent called Edex or Caverject, or combination
now,
called Trimix.
What is that? So you have to take a small, little diabetic needle and put it into the penis?
Yeah,
on the side of the penis? On
the side of the penis near the base. It's a very small little needle, so we teach patients how to give themselves an injection. And that'll get
I don't care how small the needle is. It's still going to be to a lot of guys. It's still putting a needle in my penis.
Right.
I mean, right?
Yes.
But some guys go for that?
Oh, yeah. Still, some patients will still go for it, as opposed to, say, an implant.
Yeah.
Or it can be a bridge, at least in terms of trying to get the erection back before they consider more permanent solutions, such as an implant.
Probably diabetics go for that pretty well, because they're already used to, especially the insulin dependent, because they're already used to giving themselves injections.
Yeah, the diabetics seem to, although many men, even if they're diabetics, just don't like that whole concept of sticking a needle in their penis.
Yeah.
So there's other things that we can use, such as vacuum devices. There's a treatment that uses a urethral suppository called Muse, which we can use. So there's other things that we can try, depending on patient preference and underlying condition.
But I guess for Carl, if he's had surgery already and he's had prostate surgery, can you put the implant in him? I mean, is there any reason? I mean, because he's had surgery already, can he not get the surgery, or can he?
Oh, yeah, absolutely.
Yeah. So why not? Why just mess around with all those needles and pills and everything? Why not just go for it?
Well, when I see the patient, I want to have him informed of what the options are.
Of course.
So we're going to talk about the pros and cons of each, and then I don't feel I have to make the patient go through all these other therapies before he does decide for the implant. If he's a good candidate for an implant and he's not respond to oral therapies, or he can't take it because of such as Carl's situation with his vision, then we'll offer him that option.
Now, does the pump ever not work, or does it ever pop, or anything like that?
They do occasionally malfunction, but we have some patients 15 years still doing fine with their original implant.
Oh, great!
So they're very durable and very long lasting.
Okay. Thanks for your phone call, Carl. Let's go to Jimmy in New York. Good morning, Jimmy. I have just a few moments left. Go ahead.
Good morning, Doctor. I'm 55. I was an ex-smoker, and I quit for a pretty long while now. And I was recently diagnosed with Peyronie's disease, my local urologist told me he tried shots directly into it, and then he just told me, I don't really have ED, but my penis, I lost size, and the curvature of it makes it very difficult for me to have intercourse. Is there any options for me?
Okay, that's a good question. So thanks for your phone call, Jimmy. Brett, Peyronie's disease is the condition where you can have this scar tissue in the penis, maybe from a traumatic sexual experience, or sometimes we don't know why. How do you evaluate that? Would a penile implant in him? Or?
Well, Peyronie's disease is more common than people think. It's thought that maybe 3 to 9%, and it was originally described a few centuries ago. And it's a condition, as you mentioned, where scar tissue develops on the penis, and so you can get curvature and deformities and erectile dysfunction. these patients, I believe, need to be thoroughly evaluated. So I will do, as I mentioned before, a blood flow study. We can sometimes see the scar tissue. It's important to know, is there calcium deposits in that scar tissue? Because you can sometimes see calcium deposits. And then we'll assess the erection by doing a blood flow, because it's important to determine, does he have a good quality erection? And this gentleman, Jimmy, you probably underwent what we call verapamil injections. Verapamil injections have been shown in some patients to improve the curvature, soften the scar tissue. There is a new drug that will become available. It's not available yet. It's called Xiaflex. It was submitted to the FDA in November last year. We probably won't get a ruling until November, but it's anticipated that it will be approved. And it's been shown in clinical trials to significantly improve the curvature, and it is injected into the scar tissue. So there's still some hope for you, Jimmy. When those treatments don't work, we can do procedures to straighten the penis out. So there are solutions, to this condition.
Always good to straighten the penis out. Absolutely right. Well, Brett, you have a lot of different treatments there for. What is that noise?
That's my phone. Sorry.
Oh, God. Okay. Well, you have a lot of different treatments there. This was Dr. Brett Mellinger, a wonderful guest on Katz's Corner. His number is 516-873-5353. In the few moments left, Brett, any other things that you think that we left out to let people know about how to manage this condition?
Well, we did talk about checking testosterone. I think it's important. We didn't talk too much about it on the call-ins and the discussion, but many of these conditions that lead to ED also lead to low testosterone, such as diabetes or high lipids and high blood pressure. And it's not just testosterone is not just for sexual function. It's a very important hormone for a lot of functions in the body. So it's important that patients get their testosterone checked too when they have these complaints and issues.
Thanks a lot, Brett. We'll have you on again, because that's a whole nother show, talking about the role of testosterone and how that affects, well, not only the erections, but a lot of different other conditions in the men, as far as their overall energy level and their cognitive thinking. Thanks for tuning in, everyone. Thanks, Mike, in the studio, and Adam for taking the calls. I appreciate that. And again, that was Dr. Brett Mellinger at Winthrop University Hospital. That's winthrop.org. This is Dr. Aaron Katz.